Managing the unexpected IFIS patient without trying. A 5-step plan. Steve Dewey, Colorado Springs, Colorado. Identifying tamsulosin as the leading cause of IFIS was brilliant. We were able to target patients taking this medication and perform special precautions that allowed us to reduce the rate of iris and capsule damage. Our protocols for dealing with patients taking Flomax were fantastic, except for one problem. This individual, for instance, couldn't remember he was taking Flomax to save his life. This only points out the autoamnestic effect associated with IFIS. Tamsu, meaning I won't remember, and losin, the old Latin word for to tell you I'm taking this drug. So why is it we respect IFIS so tremendously? Well, it's a common or not uncommon occurrence. It's got multiple etiologies. It's got medium predictability, variable presentation, and of course, devastating potential. IFIS is just too significant to concentrate on a specific subset of individuals. So if special treatment really does reduce the rate of damage, why aren't we using these steps for everyone, or do men with large prostates just deserve better treatment than the rest? So the premise, all patients become potential IFIS patients. The history or lack thereof then becomes superfluous. Special steps to improve the IFIS outcome take place for everyone, regardless of risk. And most importantly, any small pupil encountered is treated as an IFIS case. And that way we're not going to intentionally manipulate the pupil and worsen the tone. Outlined, we start with intracameral dilation. We go to improve chamber stability. We add appropriate viscoelastic choices, safer phaco instrumentation, and last, stable mechanical iris retraction. Intracameral dilation is the big one. We start with 1 drop of tropicamide preoperatively, just as Myers and Sugar identified. Moving to the intracameral mixture, the most important thing is that we don't dilute the epinephrine below half strength. Yes, the pH is going to be slightly lower, but it's only in the anterior chamber for 30 to 60 seconds, or basically long enough to see an effect before it's completely displaced with viscoelastic. With regards to incisions, I think this is really one of the critical steps. We want to control leakage. Here we're going to perform viscomydriasis, getting a good large pupil for capsulorhexis. Now that was a pretty big pupil, but look what's going on here. We have prolapse of the iris through the side port. You've probably noticed by now that the most challenging IFIS patients are, of course, the ones with the densest cataracts. Here we've actually got well over 30 seconds of ellipse time already encountered. A little dispersive viscoelastic, though, reposited the iris. We repositioned the side port, and were able to complete the case without difficulty. Iris stroma did suffer some damage. Fortunately, the patient was absolutely asymptomatic of its presence. In addition, we want to use smaller phaco needles. The smaller gauge is better. And with regards to phaco settings, in my experience, low flow phaco with a small pupil leads to retained fragments. Higher flow is problematic if one is feathering the foot pedal in and out of position 1. And last, Venturi vacuum has the advantage of improved followability, but with less fragment chasing compared to a peristaltic pump. With regards to viscoelastics, cohesives are just ineffective in IFIS cases. They work fine for distending the capsule for the IOL, but they don't work at retaining or repositioning the iris. Dispersive and viscoadaptive agents are effective at viscomydriasis for the capsulorhexis, but this is transient. They do plug the incision to block movement or flow, and they can be used to reposit or reposition the iris. Safer phaco instrumentation. It's like an airbag, it's like a seat belt. Under ideal conditions, the lowest point of pressure inside the eye is going to be the lumen of the needle, and thus the capsule and iris will find the lumen on occasion, IFIS or not. Sharp needles are safe, provided you can get off the foot pedal in time to avoid damage. I'm not that fast. I use a rounded phaco needle, which causes less damage to the iris or capsule. Here's a grab. I was going into the anterior chamber to get a stray fragment. Peristaltic vacuum doesn't have quite the followability of Venturi, and all I did was go in foot pedal position 2 to withdraw the fragment. Of course, the iris made it to the lumen first. Because of the rounded edge of the needle, the iris remained cosmetically and functionally intact, just with a little loss of pigment. When enlarging an iris in an IFIS case, it's important not to stretch it and expect it to function. This incidental strafing of the iris as I go in to do hydrodissection was performed on the fellow eye of the patient that I introduced our video with, the one who didn't remember being on Flomax. Well, I was wise this time. I used intracameral dilation, and then my own blunder actually undid all of the benefits. Now, we didn't lose any pigment, didn't have any damage to the iris stroma or sphincter, but the prolapse out of the incision was immediate and emphasizes that any iris manipulation worsens the IFIS effect, and all efforts should be made to mechanically improve dilation in the form of a stable platform, whether this is an iris retractor or an iris ring. This is a patient who has received both radiation for malignant ocular melanoma and is now on tamsulosin. I was really pretty excited. The pupil dilated beautifully, and the yellow bar represents the extent of the maximum pupil dilation. But even in this sped up video, we're able to see that very, very quickly, with very few manipulations, the pupil is going to shrink from the size of the yellow bar to that. These cases are really obvious. The problem is the cases where we don't notice the subtle shrinkage of the pupil. Obviously, I wasn't going to be able to proceed if we were going to see the meiosis occur that rapidly. The Malyugin ring provided me a wonderfully stable platform that didn't worsen and allowed me to finish the case. The most subtle warning I got in an IFIS patient was this. Look at the iris move adjacent to the tear in the capsule as I perform the capsulorhexis. This iris has no tone, despite the fact that it's got a beautiful dilation. Moving forward in the case, we get to the point where I think I'm really done with phacoemulsification. Now, I know the side port already has iris prolapse. I didn't recognize that even though I had a good primary incision, the iris had actually gone to the primary incision and prolapsed through it as well. I could have withdrawn my instruments and maybe created a new incision, but would that have created a new problem? Well, I didn't realize that might have been a better choice until I get the iris prepared for IOL implantation and I see that the tissue has been damaged. This just highlights the friability of the iris in IFIS patients and the need to really be prepared to deal with this condition rather than reacting to it. In conclusion, anticipating and preparing for IFIS cases reduces the risk of iris and capsule damage, but it's impossible to adequately screen everyone for IFIS, and then steps taken once IFIS is identified may be too little too late to avoid complications. If these steps improve the outcome for IFIS patients, shouldn't these steps improve the outcomes for everyone else?